Good afternoon, friends. So my talk is on TL film diagnostic, Lipiview and LipiFlow specifically. Thank you, Amit, for this wonderful course. But though less, audience is there, but I'll tell you that if you have any question in your mind, please ask us. We'll try to clarify at the end of this session. And I'll be talking mostly on Lipiview and LipiFlow and to some extent on mammalian gland dysfunction. So this is a history of a girl, 8 years old. She had a history of using digital devices for more than 10 hours. And she came actually for recurrent red eyes itching and recurrent marginal keratitis for 1 year. When I asked about the screen time, her parents were very reluctant to admit that during the COVID time, she was actually spending almost 16 hours a day online classes for a leisure time on iPad, iPhone, etc. And she is continuing that habit till now. So we treated her medically. Then we ordered Lipiview. And this is the picture of her mammalian gland. You see, it is the mammalian gland of a 80 years or 90 years old person. But she is having severe dropout areas, and you see the mammalian glands are scanty, all are blocked. Her LLT means lipid layer thickness is only 29, though reference is more than 60. I am talking in terms of nanometer. And she is a partial blinker, 100% partial blinker. So this is a horrible picture for me at the age of 8 years. So mammalian gland dysfunction, lot of studies are there due to, and the prevalence is 38 to 68%. And if you see the Indian data, there are only few data are available, one from our place, one from RP center, and it is about 37 to 40%. So mammalian gland dysfunction are very important for many reasons. For like one is we are seeing this, we are living in digital era on screen, and other side we have a old population group. They are having mammalian gland dysfunction. Even for cataract surgery, there are several studies. 50% are of them with mammalian gland dysfunction, and among these 50% are asymptomatic. So there is a direct relation with cataract surgery, mammalian gland dysfunction, and dry eye. It is a vicious cycle. So there are other influences. There are plenty of papers, at least maybe more than 300, 400 papers on this. Influence of cataract surgery on mammalian gland dysfunction, assessment of tear film lipid layer thickness after cataract surgery, why the patients will come back and they will say that eye is itching and reflex watering are more, gritty sensation, all are there. All the patients used to complain after cataract surgery. Then there are certain meta-analysis of this, and more frequently it is observed those who is having pre-existing mammalian gland dysfunction. And this is the best of study I recently published in 21, that despite more knowledge and more accessible to treatment, MGD is highly prevalent among ophthalmic health workers with 61.4% prevalence. I'll show some figures. And so targeted therapy based on dynamic mammalian gland imaging is effective in improving both objective and subjective. So imaging part I am talking about, imaging is very important for laser refractive surgery also, and before and after the surgery. It is also important for other diseases, and ASCRS, they have given guideline how you look for a mammalian gland dysfunction. There is LLPP, look, lift, pull, and push. Push means to express the mammalian gland secretion. So when you are examining a patient under slit lamp for cataract evaluation, especially in the era of premium IOL, you must look for these signs before jump into the cataract surgery. Otherwise, you will be in trouble. The patient will be in trouble. So main thing is treat this patient before even doing a biometry, because biometry gives you erroneous value, maybe in the range of astigmatism, maybe in the range of absolute power. So Lipiview, Lipiscan is their previous version, and LipiFlow is the treatment part. I do not have any financial interest on this. So Lipiview is basically interferometry with lipid layer thickness, as a blink dynamics they used to say. It is infrared mammography with transillumination device. And you know, all the oil, water, they create interference, and the whole system is based on that. Normal LLT is more than 60 nanometer, as I said earlier. And normal blink dynamics, if you see that blink dynamics is different. So there is high and low. So you see these interference fringes, and you can actually guess that something is wrong. Video captured this in high and low LLT. So with each blink, this moves, this fringes changes, and it changes with the level of mammalian gland dysfunction. So as I said, that there is 90% specificity of mammalian gland, and also the blink, conscious blinking, we do not do conscious blinking, so unconscious blinking, and many people are partial blinker, and it is proved that blink is the only thing which can save our mammalian gland. So there are direct, dynamic, and adaptive transformation and dual made to have a better, especially for lower lid. So this is the normal. You see that this is taken from their images, the company's images. So there is no dropout area, mild dropout, moderate dropout, and severe dropout. You see the gland also dilated in many tortuous, dilated, then fragmented glands. All are important. Then summary, it gives this summary report like the total when the, this is actually, you see that Dr. BASAK, it is not mine, my junior, his mammalian gland when he was like 29 years age, and you see that LLT is borderline. He plays a lot of with computer and game, and his mammalian glands are not healthy. So this kind of picture we have seen in many of our ophthalmic colleagues, and that is not good for long term. So we have several patients. I'll see a series of photograph, lower lid, gross dropout, upper lid. In the left eye, you see there is globe, average LLT less than 60. Then here, both upper and lower lid, you see that gross dropout, but there is a high LLT. This is false blinks. If the patient blinks before that forcible blinks, this causes high lipid layer thickness. Then both lid, you see that few dropout areas, but again low LLT, again very low, you see 20s and 25 and 30. So again false negative. All these questions are there. And this patient, when she came she asked for multifocal lens to me. I said it is a routine practice in our hospital. We ask for, and you see that extensive dropout area with false high LLT, and this patient is not at all suitable for multifocal lenses, because this meibomian gland, if you see the lower lid in the left eye, meibomian gland virtually not there, maybe 10% is remaining. So this patient will curse you. In pediatric MGD, it is increasing. So I have shown one picture because this is the cause. Smartphone is the cause. All the kids are playing with smartphone and iPads, and because they are not going out, even after the pandemic, now the fields are open, they are not going out, and they do not have the power of blink. They have forget how to blink, and their parents are, this is basically cycle of inflammation that's going, and impact of partial blink or reduced blink on the meibomian gland is the inactivity of the glands, which can insult the meibomian stasis. I call it in simple word that it is basically disease atrophy of meibomian gland. So you see that this is 11 years old child, lower lid you see, you will really not like this picture, that 11 years old kid, what will be picture at the age of 60 years. So this is another 14 years female. You see that the picture is horrible. Again you see that this is 10 years male child, partial blinker. You see the blink rate it is, and the LLT is 25-30. Both leads at very gross dropout areas, and also the shortening of the meibomian glands. So there are treatment available, the procedure-based treatment, there are many, and there is a recent ongoing study on it, is called tear care also. So gland probing, initially gland expression, gland probing, LipiFlow, MiviFlow, lot of cysteine ILAX, IPL, and then again tear care is coming. So all have positive, negative. But I will be talking on modal LipiFlow, meibomian thermal pulsation. It is between like 41-43 Celsius. Both four leads are together, and it is actually 12-minute treatment cycle. And after 12 minutes, that it is total procedures is around 20 minutes. So everything. How does it work? Thermal pulsation, heat from inner aspect and from outer aspect, and massaging of the lids, and the activator is like this. It is expensive, but it is effective. There is protection devices, the corneal shield and lid warmer. This is silicone inflation massager, and it works like this. So you see there is a animation given by the company people. They see that it expresses the meibomian gland secretion and also activated. So there are reports of visible meibomian gland structure increases after vector, this is called vector thermal pulsation treatment or LipiFlow. And people, we want to see this kind of picture in future, but probably not. We are getting maybe isolated. And there are numerous studies are going on, IPL versus LipiFlow or LipiFlow alone, then single treatment, multiple treatment, etc. are going across the world. And you see again from treatment point of view, there are several articles, and I am telling you next decade will be the decade of MGD. Cataract business has gone, and a lot of things will be coming for this patient, and they have treated, and they have seen the astigmatism pattern has been changes, so they have changes their toric lenses, power, value, whatever. Their prospective randomized studies are there before and after surgeries. Then you have different kind of comparison of that obstructive versus hyposecretory meibomian gland dysfunction, and compared systemic meta-analysis. So a lot of people are working on it. So indications, mixed or evaporative dry eye, routine preoperative investigation, postoperative patient, I'll take 1 minute more. Postoperative patient, both cataract, laser refractive, IT professional including teachers, students now, contact lens intolerant patient, allergic eye diseases, especially in VKC, we are doing one study. In patient with continued AGMs, especially with PG analog for 2-3 years, then you have to go for it, because PG analog destroys the meibomian gland. On the other hand, we know that beta blocker destroys the mucin goblet cells. So that to educate and explain the prognosis to the dry eye patient, it is a very good teaching tool to the patient. Patient will understand. And whom do you treat? Understand the goal of therapy, willing to modify their lifestyle. It is not the only thing you have to change your lifestyle also. Affordability issue, and not that expensive. May need repeat treatment after 2 or 3 years. I have done twice in last 2 years. Additional therapy to MGD also to be continued, other than like erythromycin, doxycycline, hot compress, little bit steroid touch, ointment, massage, all these things. And it is works for PMIOL candidate, refractive surgery, older patient, pediatric MGD population is rising, IT workers, digital device. Take home message is good surface is prerequisite for any predictable outcome in cataract and refractive surgery. Dry eye, MGD are basically going hand by hand. In any cases of dry eye, ultimately it will be going to mixed type of dry eye. Pre-procedure detection and treatment give optimal outcome, good for patient prognosis and education material. Vector thermal pulsation before the patient can modify your total planning and always improves the total outcome. Thank you very much for your patience hearing.